All right. Good morning, everybody. So today is our last day for our career events in this school year, and we're getting ready for the next school year. So today we are going to learn about radiography. And we have Jennifer from PCC to tell us about radiography and what is it about? Like you can see the image and you can have a hint. And I know that all of you who signed up are here for that and very interested in that career. So don't be shy to ask questions. You can ask questions, you can unmute and ask questions, or you can ask questions on the chat. But before that, let's do a little housekeeping. As you know, you have to check in so your teacher knows that you're here in this event. And if you have questions but doesn't know how to formulate that word, this is a great questions document that you can reference to. And the evaluation form, this is how we give you attendance and give you credit. And this is a requirement for high school students to graduate in Oregon. Again, be fully present, pay attention, and participate. This is a really good time to ask questions. And again, this is our last career event for this school year. And submit your evaluation right after this event. Again, this is the only way we can give you attendance. If you don't submit evaluation, even if you attended this event, we can't give you any attendance because we won't know if you learned something. And that is it for me. Let's have Jennifer.
Hello, everybody. I do hope you learned something. So I'm going to share my screen here and I'm going to get into what radiology is. All right. Computers and I sometimes do not get along, so hang in there. There we go. Okay. So we're going to talk about diagnostic radiology and what really that is. So there are multiple forms of radiology. You have MRI, CT, X-ray, ultrasound, nuclear medicine. We're going to talk about just what X-ray is right now. So a little background on myself. My name is Jennifer Bringhurst. I grew up in Southern Utah and I did my X-ray program through a school called Dixie State, but they're changing the name to Utah Tech. So if you ever look at it, it'll be Utah Tech University. I went through their radiology program. I was the second graduating class. As you can see on the right-hand picture, that is my graduating class, girls and boys, girls in red, boys in blue. So we're pretty even. It's not always the case, but it's really good that multiple people get into the field. After I graduated from Dixie State with my X-ray license, I moved and started working in a hospital. And I started working as a nuclear medicine tech, going to school for that. And I'll talk a little bit about what that is in a little bit. And then I got my master's at school named Weber State in Utah. And from then I've just been working as an X-ray tech, nuclear medicine tech. I've worked in many different states. I've taught in Hawaii, in California, and here, worked in Utah, Hawaii, California, and here. And I've also done humanitarian missions. So I've done radiology in Southeast Asia. I've done radiology in West Africa on a ship. So I've spent time on a hospital ship, which you can see in this bottom picture is the ship that I've been on. So they have X-ray equipment there. They have operating rooms there. So it's just a hospital in the middle of the ocean. So radiology can really take you a lot of places. It has me. So what is radiology? I always say that radiology is the eyes of the medical field. We see a lot of things in imaging that you can't see just by looking at somebody. So if I was to look at somebody and then if I was to look at their X-ray, there could be something wrong with their lung that you can't see physically by looking at them. So we're the eyes. We help people see inside. We help the doctor see what's going on inside. I'm assuming most of you have at least had an X-ray at some point in your life. If you haven't, you can't feel it. It's just a quick pass and a button, a beep, and then we get a nice little X-ray. So we use photons, which travel faster than the speed of light, go right through your body and help us see your anatomy. So for X-ray, things we need to learn is we need to know all of the anatomy in the body. So you can see on the top right picture is a picture of a hand placed on an image receptor. Knowing the anatomy, as you can see on the left side, you can see what bones are supposed to look like, where they're supposed to be, and then we compare that with the image, which is the bottom right picture, of how it actually looks. So you can see in the actual X-ray, all of the bones, you can see the joints, you can see the soft tissue. Things we cannot see in X-ray are like ligaments, blood vessels. We can see some of that if we give what we call contrast, which just changes the density for a little bit so that we can see them. But for X-ray, we're really just looking at the bones. What do the bones look like? How are they interacting? So this is a quick hand. Like I said, there's so much anatomy that we have to know because we have to know if we got what we need for the radiologist. So we take the pictures and then the doctor, the radiologist reads the X-rays. And without us knowing what we're supposed to be looking for, they're not going to get the images they need for a diagnosis. So we'll go through another one. So for, like I said, lungs, we see lungs a lot. So the bottom right is how we would position for a chest X-ray. The top right is the anatomy that we're looking at. And then on the actual X-ray, you can see that we can see ribs, the 7, 8, 9, 10, those are counting our ribs. The darkness is the lung field, the air in your lungs. You can see your clavicles, which go across, they're about a third way down. They go all the way across your lungs. The heart you can see, and then your diaphragm, which helps you move. You can also see that's that white part on the bottom there. All right, so the next thing is the abdomens. We also look at a lot of abdomens. Again, so we position abdomens, we'll lay them down. We can't see what's going on just by looking at them. We can see the anatomy that we're supposed to be seeing. And then in the actual X-ray, that's what it looks like. We see a lot of bone. And if you look really closely, you can see some bowel. Usually you'll just see the air from the bowel. The liver usually shows up. It's that really dense area in the top right corner of that X-ray. The stomach is that air bubble that's coming across the spine. So we get to know all of our anatomy very intimately because we have to know it. We have to know what we're looking for in order to help the doctor. So what kind of problem? So imaging, radiography, it's a people profession. I always like to say it's a mix of art and science, right? We have the science because we are talking to people. We're working with very intricate machines. We're getting X-rays to produce at a certain energy to get an actual image. But we're also dealing with people and we have to get a good image. So we're kind of an art science mix and we deal with a lot of people. So we're a people profession and we work with patients and other healthcare professionals that are employed in hospitals and clinics. So with X-ray, we don't just have patients come to us, we go to patients a lot of the time. We'll go to their rooms, we'll go to the emergency room, we go into the operating room. You name it, if there's a patient there, we can go and we can do an image. Our primary responsibilities are to position the patient so that we can see the anatomy and make sure that it's correct perspective so that the doctor can actually get a proper diagnosis. We operate our technical imaging equipment. It's large, it's not always heavy, most of it moves on its own, but you have to know how to move it around. We have to select the proper exposure factors because we want to make sure that the lights and the darks are properly exposed so it's not too dark and they can't see anything, or it's not too light so they can't see anything. Just like if you were taking a photo with a camera, you want to make sure that you can actually see the detail that you need to see. And we have to limit the amount of radiation exposure to our patient and to us and to those that we work with. Radiation is not great for the human body. Diagnostic radiation is at a level where it's a very low dose and we get more benefits than it causes harm. So that's why we're like, yes, you need these images. Do you have to study a cadaver? So in anatomy classes, I did cadaver anatomy for my prereq, but I don't think it's a requirement that you have to do cadaver anatomy. I think it's beneficial, but I know that a lot of anatomy courses don't require anatomy labs. They have other labs that you have to participate with. But yeah, so cadavers are helpful, but it's not a necessary part of learning the anatomy. Let's see this. We have to touch and lift and support our patients. And we have to provide emotional support. We get patients that are coming to us after an accident or after a doctor's like, we need to get an x-ray, we don't know what's going on. So they're very emotional. They're very worried about what's happening. So we have to be very compassionate and empathetic to their needs. And we have to be able to be strong in writing and verbal communication. And we work as a team. Every x-ray tech is not alone. We always have somebody that we can call and have help us. So we do a lot with a lot of different people. We are always working with other departments, if you're in the operating room, you're working with the surgeon. If you're in the emergency room, you're working with the trauma doctor. So we're always working hand in hand with somebody else. And we need to be able to communicate, what do you need from me? How can I get the patient to do that? So the doctor will be like, I need you to get an AP or like 2 views of this ankle. And you look at the patient and they're not going to move. They're in a lot of pain. So how can you explain to the patient what you need them to do and how you can help them? So it's a lot of taking the medical jargon that the doctors give us and then moving it into language that the patient understands, because the patient doesn't understand all of the words that the physician tells us. We have to understand them, and then we have to translate them for the patient. So this is a typical x-ray room. You can see that there is an x-ray tube hanging from the ceiling, a bed that our patient will lay on. There's a bucket underneath the bed, which is where we put our image receptor. And in that glass window, that is our lead lined wall. So in x-ray, we use lead to protect us from unnecessary radiation. You can see lead shielding hanging on the wall for us, lead shielding in our walls. All of the walls have lead in them because we're using such a high energy photon. So that's the equipment we would most likely be using if we were bringing our patient into our room. Move it around to accommodate the images that we needed. This is how we're going to create an exposure. So we have to know a lot of techniques. So that kV is the energy of the photon and the mass is our quantity. So how many photons do I need and at what energy do I need to be able to properly expose a certain area? And it all depends. Like with chest, we need a high energy, but not a lot of photons. For knee, we need a lower energy with a little bit more photons because it's denser. There's a lot more bone. So we're going to need more photons to go through it. For pelvis, we use about an 80 kV, which is a little bit high, but we're going to use about 32 mass. So we have more photons than chest, which is like 110 at 2. So it depends on the anatomy part, the body part that we're looking at versus the energy and the quantity of photons that we need. So like I said, we do work in a lot of different areas. We do operating room. So I've worked as a operating room x-ray tech and I've done total hip. So they'll be changing the patient's hip to an artificial hip. Neurosurgery, so spine surgery, urology cases, so studies of the bladder and the kidneys. They'll do studies, broken bones when they're fixing them or they're plating them. We'll be in that. Anytime where they need to see the inside of the body without wanting to cut open the body, we are there. Anytime that they're like, I need to know what this looks like, but I don't want to do a huge incision, we're a part of those surgeries because we're helping the doctor see what's happening without having to put the patient at a higher risk. Like I said, we do imaging in the patient's room. So we do mobile procedures. That's what's happening in the top left. Sorry, my puppy is ringing the bell. So sorry. So we do mobile procedures. We go into patients' rooms and we try to minimally move the patient so that we can see what we need to see. We can get the same level of x-ray that we would in our x-ray department, but just in their room. And then we also do fluoroscopy procedures. So fluoroscopy is a little bit different than x-ray. So x-ray is like a picture, it's a snapshot. This is what's happening. But fluoroscopy is more of like a video. This is how it's happening. This is, if we were to give you what we call barium, It's a strong contrast that you can drink, and it's kind of chalky, and it's like the chalkiest milkshake you'll ever drink. It's not delicious, but it gets the job done. So we can see your esophagus as it travels down. We can see your stomach as it has barium in it. So we can see how well those body parts are working. Is the esophagus actually letting the fluid go down? Is the stomach getting rid of it and putting it into the small intestines? So we need to know how the body functions, and fluoroscopy helps us do that a lot. We can also do injections for pain management in fluoroscopy. We can do lumbar punctures where we can get cerebral spinal fluid to check if you have any infections. There's a lot of things we do in radiology that most people don't assume we're a part of. We're part of a ton of diagnostic procedures, and we are always helping the radiologist or the surgeon. We're helping be their eyes for those procedures. All right, education. So quickly, the education that you really have to have for prerequisites to try to get into the program, you have to have anatomy and physiology. So anatomy is the bony structure, the soft tissue, anything that is in the body is anatomy. Physiology is a little different. It is how are things functioning. So it's what is the system, what is the system of the GI unit? Does it go from your esophagus to your stomach to your small bowel? How does that work? So it's a lot of functionality. College algebra is another requirement. So it's not calculus, it's not pre-calculus. All you have to do is college algebra. You just need to know a few minor math equations, but most of it is, once you understand the concept, you don't have to do the math equations as much. Just to pass your boards, you have to have the math. Medical terminology. Like I said, our doctors talk to us a ton in medical jargon, and we have to make that medical language make sense to our patients. Because if I was to talk to my patients in the medical language, they wouldn't understand. For example, your collarbone, the actual name of it is your clavicle. So if I was to take an x-ray of a clavicle, the order for me would say clavicle. But what I would say to my patient is, it looks like your collarbone is hurting. We're going to take an x-ray of that. We're going to take a picture of that. Or your scapula is your shoulder blade. Things like that. So we have to know what to call it so patients understand it, and then what to refer to it as so that our doctors know where we're talking about. Your digits, so your thumb, we don't call it a thumb, we call it your first digit. Your index finger is your second. Your middle finger is your third, right? Each thing has a different thing associated, a name associated with it in the medical language. Medical terminology helps you kind of learn how to better understand that and how to make sense of changing that so that your patients understand what you need from them. And then English, I mean, we just need to be able to read and write and to communicate. And a lot of our patients don't communicate in English, and we need to be able to work with a translator. If that's the case, we need to be able to work as a team with everybody. We can't do it on our own. We use a lot of translators. We use a lot of transporters, people who bring us patients. We work with a lot of doctors, a lot of nurses. Yeah, we're in every department. We go to the NICU and see the babies, and then we'll go to the ICU and see the really sick patients. We'll go to the ER and see the person that's had some traumatic experience. And so there's blood. We see blood, we see guts, we see a lot of stuff that you're like, if you're a little squeamish, it might not be for you. But I've worked with a lot of people who don't like blood, and they make it work because they work in a clinic where they don't see blood. So there's aspects of it that you can get to if you're like, nope, no blood for me, or no needles for me. There's different aspects of imaging that you can go into. Our program is 7 consecutive terms, so it's a little bit around, it's around 2 years. You'll do clinic, which is when you're working in a hospital as a student, and then you'll do our classes where we teach you all of the information that you need to know. So I'm just going to go quickly over the program courses, and then we're going to just do some scenarios a little bit. So program courses, You're going to learn positioning, radiographic positioning. Every different anatomy part has a different position. And if it has a joint in it, we're going to get 3 views versus if it's a long bone. So like your forearm is a long bone, we'll get 2 views 90 degrees from itself. Your hand has a ton of joints, so we're going to get 3 views of that. So that's kind of what we're teaching you. How many views do you need to get for that specific body part? Like your skull is a lot of different views. And so we can see, we have to do a lot of different positioning. Ultrasound is a unique part of radiography. So under the medical imaging umbrella, ultrasound is its own licensure, just like MRI, just like CT. Ultrasound uses sound waves to get imaging opposed to photons. So it's a different way of doing imaging, but it gets a lot of different anatomy parts. But it is a different part of the umbrella. You do patient care because most of what we do is dealing with patients. We learn how to work with our radiographic equipment. How do we produce an image? What happens to the body part with radiation? So we do radiology, biology. What is affecting? How is it affecting the body? We do a lot of time with clinic because the best way to learn how to do imaging is to do imaging. You do hands-on work your whole time that you're in class, because that is the best way to solidify. If I move the body part this way, this is what the image actually looks like. So you can kind of get a better sense of it. And we do a registry review. So after you take the course, you have to pass the National Board's licensure exam. And once you do that, then you can apply for your state license and work. And each state supports the national registry. So you only really have to take the one exam. So why does radiology make a difference? So when I was in West Africa, we had a lot of patients who hadn't seen a physician in a really long time. They were what I would call things that I would read in a textbook here in the States, and then I'd go and I'd actually see it. So this patient has what we would call as bow-legged. So their knees, when they were young, they weren't getting enough nutrients. So when they started to stand and learn to walk, their bones were softer than they should have been. And so they started to bow to bear the weight of the patient. So this is her walking. So you can see that her legs, they're not straight like they're supposed to be. So they came to us, we took an x-ray. The x-ray on the left shows what the anatomy looked like. You can see that the knee is not sitting on, so your femur and your tibia are supposed to sit like this. So one is round, one is flat, and they're supposed to sit on top of each other. Hers are off to the side a little bit. You can see that the anatomy has shifted. And so we can see what she has to what she needs. So in the right picture is after surgery. So what they did was they changed her tibial plateau. They kind of cut it and rotated it so that she would stand more straight. And in my experience, X-ray technology from our country to another country. So we have, I would say, more advanced rates to X-ray technology, but the way that people create photons from one machine to the other, that doesn't change. It's just like the dose, we can cut our dose by a lot less because we're using digital imaging versus film or computer radiography, which is, so film is where you physically can hold it and you shake it and like a photograph. So we can do film. But I've seen some great in the Philippines. So when I was in Indonesia, their equipment versus our equipment was very similar. And then when I was in Guinea in West Africa, we would go to their MRI machine and they had one MRI machine in the whole city and they were happy to have it versus us who has 2 or 3 MRI machines in a hospital itself. So we have more access to x-rays and to imaging procedures, but the whole technology, I say we're just more advanced. We have the newest and the best, and they have stuff that works and it gives us the images that we need. So after her surgery, she was casted for a while because we needed her to heal. They make the patients get up and they make them stand. So schooling, the first step is pre-medical imaging, and then you apply for radiology. Yeah, so the prerequisites that we have once you get into college are very similar to like nursing or dentistry. So if you're like, I don't know what I want to do. Do I want to be a nurse? Do I want to work in radiology? The anatomy, the physiology, all of those things, those prereqs are very similar in most healthcare fields. And so if you just do the prereqs for one, you're most likely going to be able to apply to multiple programs, which is nice because then you can be like, I still don't know. I had one person who applied for nursing and x-ray, and he got into nursing and he loved it. And I was like, great. Like, we're sorry to see you go, but yeah, nursing is a great field. And so it's nice that our prereqs and their prereqs work hand in hand. But yes, prereqs, and then you apply for the specific program. So after her surgery, this is the same girl walking again. So you can see a huge difference in the way that she walks. And that's why radiology matters. Like, we helped that happen because we were the imaging. We were the person that said, this is how her bones are sitting. This is how her anatomy is, and it shouldn't be this way, so that the doctor could go through and plan a map to create a surgery case to make it fit the way that it needed to. And this is just one of case. You can see the little girl in the cast sitting next to her. She also had surgery because of her leg. The things that we are able to help doctors do is mind-blowing. And sometimes you're just like, oh, I'm just taking an x-ray, but we're a huge step in every patient's care. We're a big part of answering questions that they have. So our workflow, what does it look like to be an x-ray tech? So usually for an x-ray tech, you don't know what you're gonna get that day. It's different every day. You don't have a set schedule. You have patients that walk in and need x-rays. You have patients on the floor who need x-rays. And you have patients who come into the emergency room, right? We don't have a set schedule. We don't really know what's gonna come that day. So you'll receive an order. You'll look at the order to make sure that it has the patient's name, their date of birth, what the doctor wants, and why the doctor wants that. So you're going to look at all of those things, and then you're going to go get your patient. You're either going to go meet your patient in their room, or you're going to go to the waiting room. So in this case, we'll say we'll go to the waiting room and we'll call our patient. And we'll get our patient out of the waiting room and into a private room. From there, we'll ask them, what is their full name? Can you tell me their date of birth? Because we need to make sure we have the correct patient. Because anytime we're doing a procedure, you want to make sure it's the correct patient and the correct procedure done on the correct body part. So yeah, let's say they're supposed to get an x-ray of their ankle and I accidentally x-ray their foot. Like, that's not great because I wasn't doing the proper imaging. So I need to make sure I have their name, their date of birth, and then I ask them for their symptoms, because I need to make sure that their symptoms match the symptoms I have on my paper and that they coincide to the x-ray that's being ordered. So if they come in and they're having shortness of breath, but the doctor orders a leg x-ray, then I wouldn't be able to take that x-ray. If they can't talk, we use a lot of, if they don't speak my same language, I'll use translators. I've written things down before. If they have a guardian, we'll go with the guardian if that's the way that the medical situation is meant to be. If it's a child, I'll usually ask the child for their name and then ask them their date of birth as the parent tells me. But I always try to talk to my patient, regardless of their ability to communicate back to me. I always make sure that my patient knows that they're part of this procedure as much as I am. So if I have a translator, I look at my patient, I say, what is your name? And then the translator says in their language, what is their name? They answer. And the translator tells me the whole time I'm looking at my patient to make sure they know I'm looking at you. This is because this is about you. This isn't about the translator. Or if I have a guardian who is the communicator for my patient, I still look at my patient and I still make sure that they know this is about them. They are my patient. The other person's just helping me, but they are my patient. So it's a big part of making sure that my patient feels comfortable and that they know we're going to do this, we're in it together. So after I get all that information, if it's necessary, I have to have them change for the exam. So things x-rays don't like is buttons, anything metal, anything heavy plastic, zippers, those all show up in our x-rays, piercings. And so we have to remove those. Specialized. I will answer that question in just a little bit, Griffin. And then we have to explain the procedure. What are we going to have the patient do? How are they going to lay? What positions? How many images are going to need to do? And then we gently position the patient to obtain necessary images. We try not to don't ever rough handle anybody. Just explain how you want them to get there, guide them. And then once we're done, we explain how to get the results and answer any questions they'll have. So that's our workflow. And then how does one specialize into cardiovascular radiology? So if you want to be a radiologist, if you want to be the doctor who reads the procedures, you're going to want to go to medical school, and you're going to want to be pre-med, get into a medical school, and then specialize as a radiologist, specifically a cardiovascular radiologist. There are echocardiographic sonographers who are specialized. So on our side of the technologist side, we have cardiovascular imaging. So we have ultrasound techs who do cardiovascular imaging. That's a specialty of that as well. So we work very closely with, so if you want to be a physician, the radiologist, go to med school. If you want to be on the side where you're dealing with patients and you're doing the imaging, you would go to the tech school, the radiology tech school, MRI, CT, ultrasound, all of those. And then how do you tell patients the bad news like cancer? Luckily for us, we just tell our patients it's out of our scope of practice to read the images. We need to know what we need to see, and then we'll tell the patient, your doctor will get a hold of you in the next 24 hours with this information. If I know it's bad, if let's say I have a little kid that has a broken arm and I obviously know it's broken because I'm looking at the x-ray, I'll have them sit and I'll have the doctor call them, because the results can't come from me. It's out of my scope of practice to read images, even though I know what's happening because I've had all the training to read images. I'm not allowed to say, I'm sorry, you have cancer, which great for me because I would be terrible at giving that news. But we do make sure that patients feel comfortable, know what procedures need to follow, when their physician should reach out to them. And like I said, if we know it's bad, we'll go in and talk to the radiologist and be like, hey, do you want me to send this patient, or do you want to keep them here to have somebody come talk to them? And they'll usually look at the images really quick and be like, can you put them in this room? Like, I would love to. So then you move the patient to another room. So we work closely with the physicians who give the results to set up a situation where it's comfortable for the patient and for the physician who has to give the results of it's cancer or it's something else that we don't know what it is. We have to do some more research. How do you predict advancing technology will impact job outlook? So X-ray has grown significantly with advanced technology. When I went to X-ray school in 2008, I used film, which was the old way of doing imaging. And now we're using direct digital images. So just within that time span, technology has changed, and what it's done is it's used our the amount of radiation that we've had to use, and it's cut it down by a quarter of it. So we used to have to do like pelvis x-rays at like 80 kV energy, and then we'd have to use like 60 quantity photons, but now we can do them at 20 quantity photons. So we're really cutting our dose down from everything for our patients. Like their radiation dose is so much lower. They're having a lot better image quality because of it, and we get a lot better speed. Our images are on digital form, so we can spread them to many different specialty doctors. Like say it goes to one doctor and he's like, I need to send this to somebody else. He can send it in a split second. So the technology is ever evolving and it is always changing, but X-ray itself is always going to be a need. We always need to have X-ray techs because we need somebody to take those images. Do you guys accept early college students? As long as the prereqs have been met, we will take who applies. It's a very competitive field to get into. This time we just finished our application process and we had 120 applicants, and we're going to be taking less than 40 out of those 120 because it is such a competitive field and we only have so many sites, clinic sites, that we can send students to learn hands-on. But yeah, if you get everything done and you're like, okay, I'm ready to apply. I applied when I was 18, so that you can get it done quickly and you can apply as soon as you get everything met. And if you meet the field, love it. Welcome. We'd love to teach you. How hard is it to study radiography? I always say everybody can study radiography. I say if I can do it, anybody can do it. It's just like learning a new language. The amount of energy you put into it really is how much you're going to get back from it. So you have to study really hard to learn the new concepts, to learn the new equipment and the new terminology. And once you do that, it starts to flow better. It's a hard, intense 2 years, but you'll see that it gets easier and easier every term. And every time you learn a new concept, the next one goes well. Does the PCC radiography program also include learning how to work on small animals? We don't do animals. So I know that the vet technology, they have their own little x-ray part. And so they do that. So we just learn how to x-ray humans, from small humans to large humans. That is our specialty. Dental has their own way of teaching x-ray for the mouth, and vet has their own way of teaching x-ray for animals. And we do have to do a continued education. So every 2 years, we have to have 24 credits of continuing education. We have to read the new, we have to learn a concept that's new, or we have to review a concept we've already learned. And we get those through like printed magazines from our accreditator, or the Society of Radiologic Technologists puts one out. And you'll just read them, take a quiz, and you'll just be able to stay up to date on the new and ever-changing technologies. Are you worried about the radiation since you're exposed more often? So we are exposed to more radiation than the average human, but I have never been worried about the radiation exposure because it is such a low level compared to what it was when they were first discovering x-rays. So when x-rays were first discovered, they weren't using image intensifiers, they were just using photons, where we have screens that take the one photon and make it into what would be 100 photons. So it spreads the energy. And so we don't have to use as big of a dose because we're able to make it look like there's more photons when there's not really that many photons. So we're able to kind of change that a little bit. We are allowed a certain amount of radiation a year, and we have to wear a dosimeter, which reads our radiation level. How much were you exposed to this month? And if the numbers ever get high, they pull you aside, they look at what you're doing. I've never had that happen in all of my years of being an x-ray tech. I get more of my radiation dose when I work in nuclear medicine because I'm touching radioactive pharmaceuticals. So touching radiation with my hands, and I'm putting it gets injected into the patient, and it's kind of a physiological study. What does clinic look like? So clinic, you're basically learning hands-on with an x-ray tech side by side. You are there for 8 hours a day. When you first start, it's 2 days a week. And then by your summertime, you go 5 days a week. So you're up to 40 hours during the summer. And you learn to do x-rays by doing x-rays. So you'll work with a tech and they'll be like, okay, we have a chest x-ray. And we show you all of the stuff at school so that you're not like stumbling. We'll show you before. This is kind of the positioning, and then you go out and you learn how to actually do that on patients. You trial and error. You're going to position somebody and the tech will be like, no, let's change it this way. And then you'll see why you changed it. So you are actually going in, looking at your order, reviewing it, calling your patient, explaining the procedure, getting your patient changed. You're doing every step of the procedure so that you can learn what the position looks like in your brain. I've always said that everybody positions differently. The way that it works for me doesn't always work for somebody else. The way that I use my x-ray vision, if I wish I had that, I can look at somebody and be like, this is what I think their anatomy looks like inside their body without actually shooting them x-ray. So I position them so that in my brain and in my hands, it feels correct. That that position is what it needs to be. And it takes 2 years to learn all of the procedures and how to adapt from patient to patient, because each patient anatomy is different. Each anatomy part is different, what needs to be imaged. So it's a lot of learning to trust your gut in positioning. And a lot of that happens at clinicals. Yes, so I will talk about degree costs in just a second. So let's quickly go through a patient example, and then we'll go to the PCC website where it has a ton of information. So your department receives an order for a pelvis x-ray. The patient's name is Jordan Barker. What do we do next? What are our next couple of steps? Confirm his aid. Yep. So we have to go get our patient. We have to look at the order to make sure that the symptoms and the order look right. So we're going to get the patient in the room, get the 2 identifiers, and make sure that if he needs to change for his pelvis x-ray, we get him changed, because pelvises, usually people are wearing pants with a button and a zipper. And so we'll take them off, and we personally won't take them off. We'll have the patient go into a changing room. They'll change into their gown, and then they'll come back out. So the patient is wearing jeans, so we change them. So Jordan Barker looks like he's ready for his pelvis x-ray. This guy's name is not Jordan Barker. I just know a Jordan Barker, so that's why he got chosen. All right, so now that the patient is changed, we're gonna start positioning. All right, so we get our patient on the table. We have to find where the iliac crest is. So if you feel on your side, you have everybody, you can feel your pelvis. If you push in just below your ribs, about 2 inches below your ribs, you'll feel the top of your pelvis. It's called your iliac crest. So we use that body part to help position for pelvis x-rays, because we need to make sure we get all of the iliac crest down to the pubic symphysis, which is the bottom of your pelvis, and ischial tuberosities, which is what you sit on. So we need to get that whole pelvic. So we'll position our patient, get the light right where we need it. The light is an indicator of where the photons go. And from there, we set our technique and we expose, and then we get a pelvis x-ray. So what are your most and least favorite types of procedures to work on, and when you worked as? So let's see, I love the OR. I loved working in the operating room, working with the surgeons hand in hand. I've loved most aspects of x-ray. My least favorite imaging procedures are probably barium enemas, which aren't as common as they used to be. I used to do at least 3 a week. So that for a barium enema, we would take a tube full of contrast and we'd stick it into somebody's large intestines, through their anus, through their rectum, so that we could see what their colon looked like. And the reason I hated those ones so much is I just felt bad for the patient, because it was a lot of pressure going through them, and it was a lot of contrast going backwards in their body, and it wasn't comfortable, and it just was really hard to kind of be a part of it. But I've loved most aspects of x-ray. I'm not queasy when it comes to blood. The more blood, the better. Sometimes for me, I'm a bit of a trauma junkie. If I have to think really hard, I really like it. So for trauma, we'll get patients who can't do what we normally would require patients to do. So we have to adapt. We have to change our view to help them. Okay, let's see. Let's go to this web page. So this is the PCC Radiography web page. And you can see that the average salary for annual for x-ray techs is about 74 and a half. So it's a pretty good amount of money for a 2-year degree. Our credit, where does it say? I'm pretty sure it said somewhere, but it's not a huge expensive program. I would say that it's any PCC program is going to be about the same. I think it's probably about 3,000 a term, if that. And for what you get after you get a 2-year degree, and you can make almost $75,000 within your first term, or first year of working there. So these are our classes. These are the breakdown of classes that we have. And it's divided into terms, what you do. Let's see what else. And then, so for our professional standards, so this is all after prerequisite. Yep. So here's their uniforms, books. Books are expensive. They're always expensive. Tuition and fees. So if your resident is $123 per credit, so it all depends. And then which class you're taking. So including prerequisites, it's going to be about 3.5 years. Your prerequisites can take anywhere from, my prerequisites took a year to do, and then I got into the program my first term. Some people, that doesn't always happen for everybody. So it can be anywhere from 3 to 4 years to get into this program and to get it done. But it's not a huge, especially for the community college, like it's a great field to go into, because the community colleges are usually less expensive than universities, and it's a job that gets you a great deal, great bang for your buck, as I like to say. You don't devote 8 years of your life to become a physician and then are in debt up to your eyeballs. You usually come out and what you make is pretty good from what you've learned. We have immunizations that we require. And the only reason we require immunizations is because our hospitals require them for their employees. So in order to work at a hospital and to be a student in a hospital, you have to follow their immunization standards. Students, high school students can start prerequisites now. You just have to go through college and do the prerequisites. If you look on somewhere, this apply to it, it has all of what we take for prerequisites. And high school students, if you are taking college part-time, you are welcome to take these prerequisites and get them out of the way. Medical terminology is a great place to start, because it helps you learn the language, and then you can jump into your anatomy and physiology. Math, a lot of high school students are already doing this math, so you can take the math placement test, and then you don't have to actually do the math course. So that's always a great one to do, especially after you graduate, when math is fresh in your mind. You can do the math placement test, and then that cuts out that one prereq. English, a lot of these, none of them should be, like I say, super hard. I think the hardest is going to be your anatomy and your physiology. And the only reason for that is because it's all new. It's not something that we really focus on a ton. But yeah, everything you need to know is here on our programs page. I highly recommend X-ray. Like I said, it's taken me around the world. I've been able to see countries and work in their radiology departments, and things I never thought I would do because of it. And we really are patient advocates. We are there to help the patients. You wish you knew, but didn't when you first contemplated this career. So when I first contemplated this career, I was not planning on going into X-ray. I was going to specialize into radiation therapy because my mom had cancer, and that's what I was going to do, is help people with cancer. And what I wish I would have known before is the broad views that we do, the broad procedures. I didn't know barium enemas were a part of my day-to-day life. They're not anymore, thank heavens, but there's the aspects of it that I wish I would have known. I wish I would have job shadowed a little bit more in an X-ray department, so that I fully understood what I was getting into. Had I known, I don't know if I would have done it, and I'm grateful that every day that I did it. I love X-ray. But yeah, job shadowing is a huge part. And high school students can job shadow or volunteer at a hospital, so you can get hands-on experience of, is this something I want to do? Before you commit 2 years of your life into the program, always job shadow, always volunteer in anything that you're doing. If it's not X-ray, if it's nursing, job shadow or volunteer. If it's dental, job shadow or volunteer. Those things are available to high school students. And I think it's a huge aspect of learning what you want to do without actually having to devote too much time to it, which is very beneficial. Any other X-ray questions?
All right.
I have a
okay.
quick question. If there are limited spots to get into the program and someone applies and they don't get accepted, what do you recommend they do so that they can get the schooling?
Yeah, so I
radiographer?
would recommend talking to the advisor. Where were the points missed? How can we get it better? There's in the area we have PCC X-ray, Lynn Benton has X-ray, and OIT down in Eugene area has X-ray. But it's always good to keep up with your advisor so that you have a very competitive application. What can you do better? Maybe you need to take your anatomy class again because you got a B instead of an A. So things like that, always staying competitive in it and working with your advisor to make sure. Job shadowing is a huge part. We give extra points for working or volunteering in a department that has to do with patients and radiology. And if you can get so many hours, you get 8 points instead of 4. So spending your time doing that is also very beneficial.
And then if they do those items and then they reapply, is it in the reconsideration? Do you see that, well, they're really interested, and so then they kind of move up in the order of acceptance?
Yeah, so we try to keep track of who applied and who was competitive before. We are alternates. If you become an alternate, you're guaranteed a spot next time. So if you're like just not barely making it, but you become an alternate, you're guaranteed a spot in the next cohort. I think you get an extra point if you've applied before and you're reapplying so that you can become one more step closer to getting into the program. It's not usually 120 applicants. We didn't have a cohort last year. So everybody who wanted to apply last year is now applying this year. COVID kind of messed up with our clinical settings, but we're all better now. So that's why it's so competitive this year opposed to the other years previously. Usually we get around 100 at most. So I think we had 177 total, but only 120 of them were like actually in the running for it.
Thank you.
All right, students, if you have more questions, don't be shy and put it in the chat. Otherwise, what is your words of advice for the high school students entering this degree?
Yeah, my advice is to job shadow. Get out there, see if it's something you're interested in. And if it's not, find something that is your passion. Don't waste time on something that you don't love doing because of the money. It's not going to be worth it. You're going to do the degree and then you're going to hate every day of your life. So job shadow, make sure that it's a good fit for you and make sure that you enjoy it because you're working with patients every day. And if you don't enjoy it, they can tell. And nobody wants to have a grumpy X-ray tech. So make sure it's something that you're passionate about. How can you get started job shadowing? You can reach out to hospitals in your area into their radiology departments, and they have job shadowing set up there. You can also do it through volunteering as well, the volunteering in the offices, but reach out to your local hospitals, get in contact with the X-ray managers, and the person who answers the phone is the best person to answer that question. Who should I talk to about job shadowing and X-ray? And they'll send you to the manager and then you'll talk to them.
Okay, I guess that is all for today's career event. Thank you so much, Jennifer, for giving us your time and talking to these students. It's amazing. Like being a radiographer it's amazing to be in, and it's not much of a, the years of schooling is not long, and you get a higher salary.
Yeah, exactly. And that's the nice thing about X-ray. Well, if you guys have any questions, you can always reach out to me through PCC. My email is jennifer.bringhurst@pcc. So please send me any questions you might have.
All right, I'm gonna stop the recording and